I was asked about the sequence of therapy in myelodysplastic syndromes. First, we have to remember that usually upon diagnosis, we classify each MDS patient to one of the two major groups, lower risk or higher risk. There are several overlapping subgroups. Sometimes it is not that easy. Maybe it will be more accurate to classify the patients in one of the subgroups, lower, very low, and so on. However, for practical purposes, in most cases, it is easy and practical to classify the patients as lower risk or higher risk. Now let's try to go over the list of possible treatments in each of these two categories. If we are talking about lower risk, there is a spectrum of treatments which should fit the patient's situation. So in many of my patients, if they are almost asymptomatic or asymptomatic, I may just follow them without any intervention. Then, if the disease, and once the disease progresses, they become usually anemic. Once the anemia is symptomatic, the first line and the usual and the practical way is to provide and to give red blood cell transfusions. This is usually the backbone, this is usually the default treatment, and it is always effective in raising hemoglobin and improving the quality of life. Obviously, it has nothing to do with the prognosis and the development of the disease. In most countries, once a patient becomes red blood cell transfusion dependent, he or she are eligible for treatment with erythropoietin, or as we prefer to call it today, ESA, erythroid-stimulating agents. Talking about these agents, it can be Eprex in Europe, it can be Recormon in Europe, it can be Aranesp, it can be also Procrit in the US. These are very similar erythroid-stimulating agents. And if we talk about Aranesp, also it can be called darbepoetin. Recently, we have started also using some of the biosimilars such as Binocrit, and I guess other agents are available as well. If we start treating patients with erythroid-stimulating agents or erythropoietins, the response rate is usually around the 50–60%, and it lasts on the average for about 2 years. And I'm saying average, it means that in some people it lasts less, in some it may last even for 5 or 10 years. There is a question, it has not been fully solved. Should we start with erythroid-stimulating agents before patients develop transfusion dependency? And we in the European MDS group have published several years ago, the first author is Hega Garelius, and this is a paper of the European MDS group. We showed that if we start with erythroid-stimulating agent before as first line, we might delay the need for red blood cell transfusion. So I hope that in the future, this policy will be acceptable by many health authorities. But as of today, still in many countries, including my country, patients have to be transfusion dependent first in order to be eligible for a public coverage with erythroid-stimulating agents. The subgroup of patients with lower risk who have del(5q) abnormality respond quite well to lenalidomide, the hypomethylating, the lenalidomide, the IMiD, immunomodulatory drug lenalidomide. We in the MDS 004 trial published about 10 years ago. Actually, it was in 2011. The first author was Pierre Fenou. We, in this trial, showed that the response rate of patients with del(5q) and transfusion dependence to lenalidomide is around the 50–60%, and this treatment response lasts for about two years on the average, and almost 50% of them lose the del(5q) abnormality. So we can treat patients with lower risk MDS, with anemia and del(5q), with either erythroid-stimulating agent or lenalidomide, and the sequence can also be this one or that one, and then if the first line fails, we can use it as second line. It is not clear today in 2022 whether we should use lenalidomide as first line and erythroid-stimulating agent as second line in this subgroup of patients with lower risk and del(5q), or we should use erythroid-stimulating agent as first line and lenalidomide as second line. In many countries, it is acceptable to use lenalidomide as first line and leave erythroid as second line. In other countries, it's the opposite. But we should remember that both agents are effective in more than half of the patients with lower risk MDS and del(5q). So in summary, patients who are defined or classified at diagnosis or even later as having lower risk MDS and they become transfusion dependent, they receive blood transfusions, which is always the backbone, and then erythroid-stimulating agent. If they are del(5q), they may respond to lenalidomide either after ESA failure or as first line before. Is lenalidomide effective in patients with lower risk with non-del(5q)? It has been tested in several papers by Azra Raza about 12 years ago, and or maybe a little bit more, Blood paper, and we participated in the MDS 005 trial. The first author was Valeria Santini. It was published in JCO a few years ago, and in this study we showed that about 27% of the patients with low risk MDS and del(5q) and transfusion dependent people may respond to lenalidomide. So yes, they can also respond to lenalidomide, but as we mentioned, in a smaller response rate than those with del(5q). Unfortunately, in many countries, it is still not approved for lower risk patients with anemia and non-del(5q). Now, about 20 to 40% of the patients with low risk MDS also suffer from thrombocytopenia. In some of them, the thrombocytopenia, in about 5 to 20%, the thrombocytopenia can be severe and life-threatening. Unfortunately, we don't have today approved agent for these patients. In summary, what we do have, which we can offer these patients, we can offer them platelet transfusions, either if they bleed or they are before a procedure which require higher platelet count, such as catheterization, such as surgery. We are familiar with two agents. One is romiplostim, which is given as injections, and the other one is L-thrombopag, which is given as an oral. Both are thrombopoietin receptor agonists, and there are several trials in which we also participated in some of them, and several trials have shown their effectiveness in raising platelet count, in minimizing the need for platelet transfusions, and in minimizing the significant bleeding events. However, there was some concern that was raised regarding the safety of these agents, there were several patients who experienced increased blast count and even suspicion of transformation into acute leukemia. So unfortunately, these two agents, romiplostim and L-Trombopag, are currently not approved. I hope not approved yet. And I wish and pray that either these agents will be proven or will be found to be safe, or other will be found to be safe, and we will be able to offer our patients agents that are effective and non-risky to treat the thrombocytopenia, which might be sometimes deleterious. So in summary, in the lower risk group of patients with MDS, if the anemia is significant and symptomatic, red blood cell transfusions, ESA, and lenalidomide with the subgrouping that I mentioned. For the thrombocytopenia, today approved only platelet transfusions, as well as L-Trombopag and romiplostim, which are not approved yet, but are still either under investigation or under freeze from the companies. Now, what about second or third line in patients with low risk MDS and anemia after erythroid-stimulating agent failure and or lenalidomide failure? Well, currently, we do not have approved agents, but I would like, just as a snapshot, to mention 2 or 3 potential agents which are still under investigation. I'm sorry, there is one which is already approved in many countries, and I'm talking about the luspatercept. Luspatercept, the survivin analog, is available in many countries as second line after erythroid-stimulating agent failure. I would like to hope, and this is my vision, that in the future we might use both erythropoietin and luspatercept. Today, this is the sequence. First erythropoietin, plus minus lenalidomide, and then luspatercept. What happened then? I would like to mention several agents. Ruxadostat, HIF inhibitor, which is still under investigation. I can tell you that from experience in clinical trials that this is a very easy agent to take, no side effects. It might be helpful in about 50% of the patients, but still investigational. Imetelstat is a telomerase inhibitor. It is an injection or shot which is given every 3-4 weeks. Again, effective in about 40-50% of these patients, but still investigational. And I believe that we will see in the next few years several other oral hypomethylating agents have also been tested, but it's still early to say what is the real place of oral hypomethylating agent. Now let's move briefly to the high-risk patients with MDS. It has been established about more than a decade ago that the first-line standard therapy for patients with high-risk MDS is hypomethylating agent, either azacitidine or Vidaza, or decitabine or Dacogen. In many systems, it is easier to use azacitidine because, number one, it is given in short subcutaneous shot or IV, so it's convenient for the patients and the nurses. And the second point is that azacitidine, if we refer to the AZA 001 Lancet Oncology, Pierre Fennou was the first author in 2009. This is probably the only agent that has been shown to show survival advantage. But still, we look at both hypomethylating agents, decitabine or Dacogen, and azacitidine or Vidaza as similar and well-established first-line agent for high-risk MDS. However, the good news that they are effective, the good news that they are effective for about 2 years on the average, the bad news that it is effective for only 50% of the patients and only for 2 years, And some real-world data probably indicate that even these numbers are a little bit too optimistic. Maybe the response rate is no more than 40, and even 2 years on the average is a little bit exaggeration. So we must have something better. So most of the attempts today in the 2020 and on, and I guess we will see it this year and next year, probably the next couple of years, is to take azacitidine or decitabine as the backbone and to still use it as the first line, but to add something to that. It reminds us the saying of Alan Burnett, pick the winner approach. And you can see here numerous clinical trials with hypomethylated agent to all patients as a backbone for first-line treatment of high-risk MDS, and adding to that additional agent. Probably today, the front runner is venetoclax, the BCL2 inhibitor, which has been well established as excellent, effective, relatively non-toxic oral agent to treat patients with CLL and patients with other diseases also. And we are now using it in acute leukemia, which is not the topic of today, as well as in high-risk MDS. So there are several trials that have already been concluded with positive answers, and there are many others still ongoing using hypomethylating agent and venetoclax. But we are familiar with other trials. There was a trial with azacitidine and pevonedistat, which was unfortunately terminated, and the results were not that positive. I am not sure that there is a verdict for pevonedistat. There are other agents which we are familiar with hypomethylating agent and specific antibodies, such as the magrolimab, of the Gilead company, which is anti-CD47. There are studies with hypomethylating agent and sabatolimab, an anti-TIM3 antibody of Novartis. There are studies with hypomethylating agent and IDH1 or IDH2 inhibitors in the patients who have this mutation. And I'm sure that I forgot several others, which we will see in the next year or 2 years. There is also the studies, at least 2 studies, one by Clouzot from the French group, and other one from the US, studying hypomethylating agent with anti-TP53 or P53 activators. So there is a large spectrum of attempts of trials which are ongoing. Today, in 2022, we have to be clear. The only approved agents are hypomethylating agent as first line, but it makes sense to try to recruit patients to trials and to try to improve the response rate and or the duration of the treatment with additional agents. And I'm sure that in the next 2 or 3 years, we will see improvement. Last but not least, stem cell transplant is still a very possible approach. We have to remember that, of course, this is a procedure which is associated with relatively high morbidity and high mortality. However, many of the patients may benefit if we find the appropriate patient, as well as we have the right preparation and the approach, which is also post-transplant preparation and post-transplant treatment. So yes, stem cell transplant is still effective, and the transplanters are right. This is still the only curable approach. However, we have to remember that this approach, although today is offered to older people and to more people probably in the past, is still limited to relatively few people who are appropriate to this procedure. So in summary, when we have a patient with high-risk MDS, still hypomethylating agent is the backbone and is the first line treatment. Then we can think about additional agents, today still investigational, and stem cell transplant remains for relatively young, although the age is going higher and higher, and relatively people who can make it. Thank you.